everybody. Hope you all are fine. The lecture for today is about the ossification or bone formation. The fourth session in the series about skeleton. So at the end of this session, the participant should be able to define ossification and list the types of ossification, describe the process of ossification, that is intramembranous and intracartilaginous. Describe the growth plate, cartilage, its role in ossification and its fate. Describe the process of development of Haversian system, spicules, trabeculae and formation of medullary cavity. Tabulate the bone cells, their functions and location. Describe the process of bone remodeling. Describe the process of bone repair and what is the role of an orthopedic surgeon in the management of a patient having fragility fractures. And at the end, enlist the factors affecting the bone growth and review the fracture management. Ossification is the process of bone formation, which includes both production and remodeling. It is also named as osteogenesis. Ossification starts during intrauterine life when embryonic mesoderm transforms itself into mesenchyme, which is a loosely woven tissue having a few star-shaped cells and fibers embedded in a large amount of homogeneous semi-fluid intercellular material. Mesenchyme develops into all types of connective tissue, including skeletal tissue. Embryologically, there are two methods of ossification. Number one is intramembranous, which is also named as membranous or direct method of ossification. The second one is intracartilaginous or endochondral or indirect method of ossification. Now let us start with intramembranous method of ossification. In this method, bone tissue develops directly from mesenchyme, hence this is also named as direct method of ossification. It is a fast process involved in the formation of flat and irregular bones required urgently for support and protection of viscera, such as bones of vault of skull, face, and clavicle. Intramembranous ossification process starts during second month of intrauterine life, and changes take place in a sequence, which start as recruitment and condensation of mesenchymal cells as the osteoprogenital progenitor cells in the shape of a membrane. This part is now named as ossification center. This center gets increased vascularization at several points by ingrowth of capillaries, that is increased vascularity, which leads to proliferation and differentiation of progenital cells as the osteoblasts, which cause a cascade. Formation of osteoid in the shape of collagen fibers embedded in ground substance. This causes imprisonment of osteoblasts, which become progressively distanced from each other but remain connected through thin cytoplasmic processes and transform themselves as osteocytes. They produce alkaline phosphatase, which cause mineralization of osteoid, that is deposition of calcium, and the process is named as calcification. This causes osteocytes to become trapped in the lacunae, and their processes become enclosed within the canaliculi. In this way, a layer of calcified osteoid is formed, which is also named as matrix. And this layer, calcified osteoid layer, is also named as a lamella of bone. Addition of multiple lamellae, one over the other with a central vessel, is named as Haversian system or an osteon, which consists of multiple lamellae with osteocytes in between and a Haversian or central canal with vessels. Several such osteons unite and produce needles-like bony spicules, which unite and merge and produce trabeculae. This process occurs at several points, and these trabeculae become connected to each other. Initially, this process produces sponge-like bony tissue in the shape of trabeculae and spaces, as is seen in the central part of the flat bones. Later, more and more trabeculae are formed and the bone tissue become converted into compact bone, as is seen in outer and inner tables of flat bones of the skull. Remodeling of the bone takes place with the help of osteoclast and osteoblasts. At the same time, condensation of mesenchyme around the newly formed bone becomes the periosteum. Second method is intracartilaginous method of ossification. This process of ossification involves two phases. Number one, formation of a cartilaginous module of the proposed bone from the mesenchyme. Number two phase is removal of the cartilaginous tissue and replacement by bone tissue. This phase involves two basic events. Number one is destruction and removal of cartilaginous tissue, and number two is replacement of this area by the bone tissue. Both these events are occurring side by side at the same time. Notable point is that in comparison with the intramembranous method of ossification, there is an intervening stage of cartilage. Hence, this method of ossification is also named as indirect method of ossification. Hence, it becomes a more layerly phenomenon. And most of the bones of the body develop through this method of ossification. We start with the first phase of intracartilaginous method of ossification, that is for formation of a cartilaginous module. This process involves a series of events which start with the condensation and recruitment of mesenchyme cells as the chondroprogenitor cells. These chondroprogenitor cells proliferate and differentiate as chondroblast. The chondroblasts produce matrix in the shape of fibers and ground substance. The chondroblasts become imprisoned within the matrix produced by themselves, and differentiation and maturation of chondroblast leads to formation of chondrocytes. At the same time, mesenchymal cells at the surface produce a fibrovascular cellular membrane perichondrium. In this way, a module of cartilaginous tissue is formed. Second phase of intracartilaginous method of ossification comprises two steps: destruction and removal of cartilaginous tissue, and number two, replacement by the bone tissue. First, the destruction and removal of cartilaginous tissue occurs all over the bone except articular surfaces, where it persists as articular cartilages. In central region of the shaft of the cartilaginous module, due to relative less blood supply, hence nutrition, the chondrocytes undergo hypertrophy and extracellular matrix surrounding them become calcified. Size of the lacunae housing chondrocyte become enlarged. This happens to be because of calcification of the intervening walls, which cause death of the entrapped chondrocytes. The dying chondrocytes release matrix proteinases, which cause weakening of the intervening walls, hence merger of the species or lacunae. At the same time, removal of the dead chondrocytes. This whole process leaves behind enlarged vacant spaces which are named as primary areolae. The second step involves replacement by the bone tissue. It occurs in the spaces or the primary areolae. Shaft or diaphysis of long bone develops from one primary center which appears during second month of intrauterine life, and ends or epiphyses develop from two or more secondary centers which appear mostly after birth except lower end of femur. The process of bone formation or ossification is as follows. Process of ossification comprises 5 steps. First steps is production of bone color. The blood vessels approach center of cartilage module and cause pericardium to differentiate into periosteum. Consequently, chondrogenic cells convert to osteoprogenitor cells, which transform to osteoblasts. This part is now named as primary ossification center. The osteoblasts secrete bone matrix and form a bony collar around the center of the cartilaginous module. Second step involves destruction of the cartilage. Bony color prevents nutrients from reaching the center, hence hypertrophic chondrocytes degenerate along with deterioration of the matrix. This leads to production of spaces or cavities in the module. Third step involves invasion of these newly formed spaces or cavities in the center of the module by periosteal bud, which is a mass of vessels or vascular sprouts which carry osteoprogenitor cells, osteoblasts, and hemopoietic cells, especially mononuclear cells. These mononuclear cells transform as osteoclasts and they produce holes in the bony color through which osteoprogenitor cells and osteoblasts enter into the primary areolae or the spaces. Hence, they produce new osteon and trabeculae in these spaces. So the spongy bone formation starts. During fourth step, Osteoblasts continue to form bone matrix on surface of the calcified cartilage. As bone matrix calcifies, a calcified cartilage, calcified bone complex is formed. Bone color continues to grow towards both ends of the bone, and osteoclasts continue resorbing the calcified cartilage, calcified bone complex. In this way, medullary or bone marrow cavity is formed. Invasion of ends of module by epiphyseal vessels leads to formation of the secondary center of ossification, which differs from the primary ossification center as there is no bone color form. Osteoprogenitor cells enter epiphyseal cartilage, differentiate as osteoblast, and secrete matrix on the cartilage framework. Increase in length of the long bone at both the ends of primary ossification center is named as interstitial growth, whereas increase in diameter by deposition of bone underneath periosteum is termed appositional growth. In fifth step of process of ossification, ossification or growth of the bone at epiphysis and diaphysis continues. The hyaline cartilage remains as epiphyseal plate till growth is complete, that is fusion of epiphysis and diaphysis. And articular cartilages remain as such as they never ossify. The epiphyseal cartilage is a transverse layer of cartilage that lies at both the ends of the bone between epiphysis and diaphysis. Epiphyseal plate is responsible for bone growth in length. Under the microscope, 5 overlapping structural zones of the epiphyseal cartilage are identified. Zone 1 is zone of reserve cartilage. This lies furthest from the diaphysis and is characterized by randomly arranged mitotically active chondrocytes. Second is zone of cell proliferation. Proliferating chondrocytes form isogynous groups in rows oriented parallel to the long axis of the bone. Third is zone of cellular hypertrophy. Hypertrophy chondrocytes move towards diaphysis. They hypertrophy, mature, and accumulate glycogen within their cytoplasm and also undergo apoptosis, hence an enlargement of lacunar spaces. Fourth is zone of cartilage calcification. Calcium ions brought by blood calcify cartilage matrix surrounding dying chondrocytes. Although matrix is calcified but is not yet ossified. Fifth is zone of ossification. Cartilage destruction and removal by osteoclasts and bone deposition by the arrival of osteoprogenitor cells which convert as osteoblasts and later transform as osteocytes. The osteocytes produce alkaline phosphatase which causes matrix to become calcified. Hence the bone tissue is deposited. Now let us have a look at the fate of epiphyseal cartilage. As epiphyseal cartilage is responsible for longitudinal bone growth, It is present until skeletal maturity. Its thickness is maintained by active multiplication of chondrocytes in proliferative zone, that is zone 2 of the epiphyseal cartilage. At the age of 17 to 20 years, the age of skeletal maturity, bone growth no more required, hence multiplication of chondrocyte ceases, so growth plate cartilage disappears, there is stoppage of bone formation and ultimately fusion of epiphysis and diaphysis. In mature bone, the site of epiphyseal cartilage is represented by epiphyseal line. Haversian system, spicules, and trabeculae. Osteoclasts excavate and erode calcified cartilage and produce primary marrow spaces, which become filled with embryonic bone marrow. Osteoblasts line the delicate walls of marrow spaces and lay down osteae, and themselves become imprisoned and secrete alkaline phosphatase, which cause deposition of mineral salts, hence the formation of multiple lamellae in this fashion. And multiple lamellae with osteocytes and a central vessel in the central canal is named as osteon. Several osteons unite and produce needle-like bony spicules. Several of these spicules unite and merge and form the trabeculae. This process starts at several points so that trabeculae produced at these parts become interconnected with each other, and this is the formation of spongy bone. At the same time, stoppage of bone formation in the centrally placed lacunae and erosive process at calcified cartilage, calcified bone complex by the osteoclasts leads to formation of the medullary cavity. Among the factors affecting bone growth, number one factor is genetic makeup of the individual. Second factor is general nutritional status of the individual. Number three is the activity of the muscles acting on the bone. And number four are the movements at the joint formed by the bone. Number fifth are the metabolic factor. Among the metabolic factor, the factors which affect the bone growth are the minerals, especially calcium and phosphorus, vitamin D and vitamin C, parathyroid hormone, calcitonin, and growth hormone. The cells involved in the bone formation and bone remodeling. First of the cell is the osteoprogenitor cells or osteogenic cells, which give rise to osteoblasts and are present in the cellular layer of the periosteum and to some extent in the endosteum. Second group are the osteoblasts, which originate from the osteogenic cells. They are responsible for bone matrix formation and are present in the cellular layer of the periosteum, in endosteum, and growing portion of a bone. Third group are the osteocytes. They are responsible for maintenance of the mineral concentration of the matrix, and they are entrapped in the lacunae among the matrix. Number fourth are the osteoclasts, which develop from the monocytes present in the blood. They are responsible for bone resorption and are present in the endosteum, cellular layer of the periosteum, and in the pits on the bone surface, which these pits are named as the resorption bay or Howship's lacunae. Bone remodeling is a balance between bone formation and bone resorption, which maintains the shape of a bone according to the age or injury-related change stresses during the lifetime. There are two types of bone remodeling. Number one is external remodeling and number two is internal remodeling. External remodeling maintains general shape of a bone depending upon the stresses involved. The process of external remodeling involves bone tissue deposition in certain regions and resorption in other under the periosteum, number one. And number two, similarly, bone tissue deposition and resorption in certain regions around the endosteum. Notable point after discussing the process is that rate of deposition and rate of resorption in any area changes or alters or maintains the shape of a bone. Second type of bone remodeling is internal remodeling, which regulate the internal structure of a bone. As certain the internal structure is constantly being changed in response to weight changes, microfractures, and changes in the posture. This bone remodeling occurs through bone remodeling units, which have got two components. Number one are the cutting cones. These are cone-shaped area or tunnels formed in the compact bone by resorption of the bone tissue by the osteoclasts. And the closing bones. When the cutting tunnels reach their maximum size, bone resorption stops and that area is encroached by blood vessels, osteoblasts, osteoprogenitor cells, which enter these cones and begin depositing new lamellae around the blood vessels, hence new formation of new Haversian system. These are named as closing cones. Now we come on to the bone repair. First, the fracture of a bone is a partial or complete break in the bone, which results in damage to the bone matrix, tear of periosteum and endosteum, kills the cells, and sometimes displaces the ends of the broken bones. And the bone repair process starts almost immediately. This process involves number one, bleeding from the cut blood vessels fills the area around the break with blood and form a clot, the hematoma formation. Number two, in due course of time, capillaries and fibroblasts invade the clot and form granulation tissue. Number three, the granulation tissue is converted into a fibrocartilaginous soft bone, the callus, and then its ossification leads to formation of a compact bone at the site of the break. Three layers are identified during this callus formation and its ossification leading to formation of the bone. Approximately within 48 hours, Due to increased mitotic activity in osteogenic layer of periosteum, there is buildup of osteoprogenitor cells, which differentiate into osteoblasts and form a bone collar which is cemented to both the broken ends. This represents the deep layer of a new woven bone on the fragmented bone. Number two, as the proliferation of osteogenic cells is more rapid than that of capillaries, there is insufficient blood supply and nutrition. These cells become chondrogenic and later differentiate into chondroblasts, which form cartilage in the superficial area of the bone collar. This is the middle layer of made up of cartilage. Third layer is more superficial layer of osteogenic cells, which have a profuse blood supply from the periosteal vessels. They continue to proliferate and form a superficial layer of proliferating osteoprogenitor cells. Concurrently, bone color on either ends of the fragmented site fuse and form a single color, which is now named the callus, an external as well as an internal callus. Cartilage matrix in between these two calli become calcified and later replaced with bone tissue. Ultimately, almost initial state is uh, regained through the remodeling process. Lastly, we take up the fracture management. Human contribution in the fracture management is only to put the broken pieces together and immobilize them. The repair process is carried out by the nature itself. Different methods used for these purposes are: splints are used to stop the movements of broken parts and are frequently used temporarily to transport the patient. They are also used by the quacks. Braces are used to support the broken parts. Very frequently, plaster casts are used to provide support and to immobilize the broken bones. Traction was a very common process in the management of fractures previously, but is a very less common option nowadays. Nowadays, a very frequent option is internal fixation, in which surgically metal rods or plates are inserted to hold the broken bones together. The role of an orthopedic surgeon in the treatment of patients with fragility fractures is twofold. Number one, he is responsible for the conservative or surgical treatment of the fractures. Number two, he is also responsible for the prevention of further fractures and establishing diagnostic and therapeutic procedures for prevention of the osteoporosis. Comments and suggestions will be welcomed. Thank you for listening and watching.